Before the presentation begins, I would like to just tell you a little bit about SHARE. SHARE is a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with women's cancers and provides outreach to the general public about signs and symptoms, because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, or our helpline, please visit our website at sharecancersupport.org. We ask that all participants stay muted during this presentation. When Dr. Horton, who is our guest speaker, finishes presenting, we will begin a Q&A discussion. You're welcome to submit questions throughout the presentation in the chat feature at the bottom of your screen, and I'll put a little note in the chat as well, just so you can see where that is. And then I'll ask the questions at the end. Because we are recording, if you speak, then you will show on camera, which some people are fine with, but others might not be. So if you want to ask the questions in the chat, then I will ask them of Dr. Horton here at the end. So now I'd like to hand it over to Dr. Horton herself, who will be today's speaker, and she'll do a quick introduction before launching into her presentation. Dr. Horton, thanks for joining us.
Thank you. Thank you for having me. I'm excited about talking about a topic that is interesting to me, hopefully interesting to others, the history of chemotherapy. It's a lot of information. So hopefully people will, as you develop questions, please send them on in. So I'm a medical oncologist based in Washington, D.C. I've been in treating cancer for over 20 years. I left my fellowship in '99. It seems like it was yesterday. I'm sorry, that's my dog. Let me close my door.
We always like when dogs join us.
I have like an Akita with a really loud bark. So yeah, I've been treating cancer for over 20 years, focusing on breast cancer. And I have focused, my passion is clinical trials, health disparities, and breast cancer. So that's most of my career. I started out in a private practice in Annapolis. I was at Georgetown, then I went to Howard, where I spent the bulk of my career for about 10 years. I was their director of clinical trials, and we did a lot of work with breast cancer. I then left and went to FDA and approved drugs in the breast cancer division in GYN and ONC, and saw another side of how we develop our drugs and run our clinical trials. And so now I work for a nonprofit in San Francisco. It's kind of a spinoff of UCSF that houses one of the big neoadjuvant clinical trials, the I-SPY breast study, among others, Wisdom Study. And I'm their executive director of access and diversity. So I work on increasing representation from all underrepresented populations on their initiatives, as well as other trials. And we work with breastcancertrials.org. So that's my kind of unconventional history. But today I was asked to discuss chemotherapy, the history of chemotherapy. And at the very end, I'll talk a little bit about specifically chemotherapy and breast cancer. All right, so we'll jump right in. So this is just a quick overview. I'll talk a little bit about what chemotherapy is, and then the history of the development of chemotherapy. A little teeny bit about breast cancer, chemotherapy milestones, just three, what I consider just global important advances in chemotherapy. And then the last slide is just some very general side effects, and we can talk about that more and go into more detail, but this was just kind of a quick overview. So what is chemotherapy? So we know that chemotherapy is a powerful weapon against cancer. It's a broad term, but it's a treatment option for treating cancer that uses chemicals. And the chemicals are targeted at destroying the cancer cells throughout the body. And you may hear the term systemic therapy, which some doctors may use instead of chemotherapy. It just means that opposed to radiation and surgery, which are local treatments that just affect the spot that they're directed to, chemotherapy goes through the bloodstream throughout the body and is systemic and can actually treat any place that the blood goes. The word chemotherapy is a breakdown of chemochemicals and therapy, treatment to treat diseases. So the use of chemicals to treat disease. Slide. There we go. How does chemotherapy work to treat cancer? So the way that chemotherapy works is that it's targeted towards the cancer cell, and the chemical is, I'll say, attracted to quickly dividing cells. And we know that that cancer cells, one of the hallmarks of a cancer cell is that compared to normal human cells, it's rapidly dividing. And it's, my general definition of a malignant cell is a rapidly dividing, disorganized cell. So if you have a breast cancer cell, it's your normal breast cancer cell like any other, but for some reason, and it's usually a combination of changes to the DNA over the course of your life, it ends up in this scenario where your body isn't able to repair those changes, and it starts to rapidly divide and not work the way it's supposed to, like a normal breast cancer cell. And as those cells divide and it becomes a bigger mass, again, that's when you will notice how we see tumors grow and how they're identified. The problem with cancer, and we always say cancer in and of itself, it's not painful, but as it grows quickly, then it starts taking over the space where the normal cells usually do their work. It could cause pain and pressure, and it becomes apparent to us. But chemotherapy works by getting into the cells of these rapidly dividing malignant cells and basically just stopping the ability of these cells to grow and divide. So we call it direct therapy to the cell. And the goal with chemotherapy is, one, to stop the spread of the cancer and stop the dividing. Two, to start to kill those cells and shrink down and cause regression and hopefully eradication of the tumor. If someone has had surgery or radiation for an early cancer where all the cancer that we can detect with our eyes and with our imaging is gone, and we use chemotherapy in what's called the adjuvant setting, meaning after there's no cancer that we can see, but we want to prevent recurrences, chemotherapy is used in that instance to prevent a recurrence from happening by hopefully going throughout the body and killing any micrometastatic cells that aren't picked up on any of our technology that we know can be still there, because we know that recurrences do occur. And then we do know that chemotherapy can cause side effects, or may cause side effects as well. And there's a range of those we'll talk about. So the historical development of chemotherapy. Now, here's the history part. Now, so if you want to start back, I'll start in 1900. So from 1900 to 1940, we call that the model development stage. We didn't really have any chemotherapies back then. We knew that cancer was a disease, and that most of the writings were about blood cancers, leukemias, lymphomas. And one thing that they were trying to do is figure out how we can test these chemicals. And the thought is that you need powerful chemicals to kill these cancer cells that nothing else is treating. And so they developed what's called transplantable tumor models in rodents, basically, during that period. So around 1940s with World War II, they weren't really looking for it, but it was supposed to say nitrogen mustard. They noticed that mustard gas, which is a chemical warfare gas, it wasn't used in World War II. What they say is that there was an airplane that had an accident, and mustard gas landed on some of the soldiers. So they were able to see some of the effects of mustard gas, which causes, blistering of the skin, the obvious. But they also noticed that when they checked their blood, that they were neutropenic. So, they said, well, this really kills white cells. You fast forward a little bit, and there were two pharmacologists at Yale, Goodman and Gilman, who took a variant of mustard gas, nitrogen mustard, and kind of an easier form of it. And ultimately, they started looking at cancers that had a lot of white cells. And they found that it was very effective in Hodgkin's lymphoma. So that was the first kind of use in the 40s of what we consider now chemical chemotherapy. And from that discovery, there was the development of similar agents from the nitrogen mustard family that are alkylating agents, which were kind of the first class of chemotherapies that were developed. So the second real class are the antifolates in 1948. And again, during this time, the 40s and even the 50s, most physicians did not believe that you can treat cancer with anything systemic. They felt that anyone who was, they looked down upon physicians who were doing that kind of research. They called anything tested for as chemotherapy was called poison. It was literally just called, that doctor who has his poisons. And so there were a few researchers who were persistent. They felt that there was something to using chemicals to treat this cancer. And at Harvard, Sidney Farber discovered what we know now as methotrexate, which is an antifolate. And it was effective against leukemias. And so most of the early successes in cancer chemotherapy were with blood disorders, with the blood malignancies. And so methotrexate was used in ALL, and it caused the first remission in 1948. So that was the first time they were able to really show that a chemical can kill cancer cells and cause them to basically go away. The second group of class of cells, let's see, were the vinca alkaloids. I'm having problems with this. Okay, so the vinca alkaloids, these are plant-based. And again, they were used mainly in the hematologic, the blood disorders, but it was vinblastine and vincristine. And so now we're getting this kind of critical mass of a few chemotherapies, that are actually working. And there's starting to be some support for starting to have some regulation of this. And they developed in 1955 the Chemotherapy National Service Center. Now, the NCI, the National Cancer Institute, was actually instituted in the 30s. And, they tried to do research with chemotherapies, what they were calling chemotherapies, and they were so unsuccessful that it kind of disbanded in the 50s. And so it's been a long road of trying to prove that we can really do this. So in 1955, we had the Chemotherapy National Service, and there we go. Then we look at the 60s to the 70s now. So 5-fluorouracil was the first chemotherapy that was developed for non-hematologic cancers, so for solid tumors. And we still use 5-FU. We used it in breast cancer, not so much these days, but it's still the backbone of the treatment for colon cancer. It's used in a lot of hematologic malignancies. But at University of Wisconsin, they worked on and developed the fluoropyrimidines. So by the time the 60s came around, they had seen that there were drugs that were effective. Most of the time, this was in the metastatic setting, in the advanced setting where, they could see the cancers and they could see them regress. And so they set their sights on cures. They were really trying to push for big effects. So they started combination chemotherapies, adding them together. If one is good, two is better. And so the first success, again, was in the hematologic diseases, the leukemias, where they use MOP combination. And MOP or CHOP, if you know lymphomas, you may have heard those, Hodgkin's disease. But back in 1967 was the first time they used a combination chemotherapy, and the cells just went away, and so they had this durable response from a chemotherapy, which again led to more support and more supportive research in this area. So MOP has been a huge success in that by the end of the 70s, they had reduced the mortality risk from by 65%. And so they had really made a scientific, finding that changed the survival outcome. And so it was felt to be a little bit more valid. And in 1971, we had the passage of the Cancer Act. And this was President Richard Nixon passed this. And this, we heard that term war on cancer a lot now, but this was the first time it was coined, and it is considered the first, quote, war on cancer. And that led to this big influx of funding for the NCI, for the cancer institutions, for research. The cooperative groups formed. We don't really, if you're not familiar with them, it's an old term. I'm old. So back in the day, a lot of the research was supported by the government. And instead of pharmaceutical companies supporting research, we had the government supporting these cooperative groups. And they were called ECOG and NSABP. And there were just a number of groups supported by the government with all kinds of investigators. Okay, research for cancer treatment is good now. People are saying this is something that might work. And the subspecialty of medical oncology became a reality in 1973. So it wasn't really a subspecialty until the 70s. And in the 70s, as people became more comfortable with using the successful chemotherapies in the metastatic setting, most of the time, again, it was just people who had advanced cancer, and they would use these drugs and they could see the effects of it. People started thinking about the use of chemotherapy in the adjuvant setting. So they knew that, yes, we can treat this breast cancer with surgery and radiation, but you know what? We're still seeing this larger than we're comfortable number of women who are having these cancers come back, and they're coming back in different places, not the breast. So these cells are getting out. Is there a way we can use treatment before it becomes metastatic to try to decrease the chance of recurrences? And so in 1976, they had already started testing a combination chemotherapy for breast cancer after surgery. And so it was called CMF, cyclophosphamide, methotrexate, and 5-FU. And it was successful at decreasing recurrences, and also they felt survival. And so it became a standard. And CMF, even, so that was 76. Most people are familiar with adriamycin Cytoxan, or AC, as the kind of standard adjuvant chemotherapy for early breast cancer. But CMF and AC were tested together, and they were the very first adjuvant treatments, and they were felt to be equal, but CMF was 6 months versus AC for 3 months, and it was more toxic. So adriamycin, or the red devil, or the chemotherapy that's red, if you're familiar with it, with cyclophosphamide became the standard adjuvant treatment. And let me go to the next. So this is just a timeline. I mean, I've talked about all of this, but I just thought it was a kind of a cool slide. And you just see how long things take sometimes. Luckily, things are moving at a much faster pace in terms of drug development, but the whole, first part of the 20th century was just kind of trying to work out how we can even test these drugs in animals. And then by 1960, we had about 5 chemotherapy drugs. And so we were just kind of getting revved up, the first half of the century.
Dr. Horton, while you're still talking through timeline and history, what was the standard cancer treatment between 1900 and the 1940s if chemo wasn't really part of the conversation at that point?
So most of the treatment was local. It was surgery. If they could cut it out, they would try to remove. And as you may know, there were some pretty barbaric surgeries that were done at times to try to remove as much cancer as possible. And then, with Marie Curie developing radium, we use radiation at times. And so that could be very toxic. So it was limited. It was limited until, nitrogen mustard became one of the first chemicals that they developed that they could safely use.
Yeah.
So not much before the 40s.
Thank you.
Oh, sure. All right, so we're jumping to the 70s now. So late 70s, but 70s. So 70s were really exciting for just a couple of advancements. One was in testicular cancer. In 1978, at the University of Indiana, which is still kind of the home of treatment of testicular cancer, and that's because they were key in developing cisplatin. And cisplatin-based treatment for testicular cancer was phenomenal. I mean, their cure rates went from 10 to 60, and this is curing. And they found that they could even cure metastatic disease. So they were taking someone who had a solid tumor, a testicular cancer, who had metastatic disease, and used just chemotherapy to totally eradicate it. And it's, this is in 78, and it has not been able to be replicated. It was just one of these, cancers was super sensitive to this drug, cisplatin. And as you may remember, Lance Armstrong, he's this great cyclist, and in the midst of his career in the late 90s, he was diagnosed with testicular cancer that metastasized to his brain and somewhere else, lung or liver. And, you hear that and people thought, okay, that's the end. But he was treated at Indiana. He was given cisplatin. Everything went away. He went on to, win multiple Tour de France's. So that's a big home run there. And also in 1978, we saw the first use of the anti-estrogen tamoxifen, which we're probably all familiar with. It's a pill, it's oral, it treats estrogen and progesterone receptor positive breast cancer. And this was not the very first time we recognized that hormone manipulation was effective against cancer. Charles Huggins, who is kind of the father of hormonal therapy, he noted back in the 40s that if you remove the testicles from a rodent who had with a tumor, priceite tumor implanted, that tumor would regress, and with nothing else, just removing the production of testosterone. And so they actually did that type of manipulation and orchiectomies in men with metastatic prostate cancer to decrease testosterone. They also found that giving estrogen to men with prostate cancer could slow down the growth. So hormonal therapy honestly started earlier, less with the use of the drugs, but more just kind of a manipulation of the organs that make the disease. And even in the 50s, the same, Professor Huggins realized that if you remove the ovaries in a woman, and they did this in a rabbit, I believe it was a rabbit, not a mouse, but they removed the ovaries, the tumor, breast tumor, would regress as well. And so we started using orchiectomies, oophorectomies in women earlier than the use of tamoxifen. But tamoxifen was the first therapy, the estrogen receptor targeted modulator therapy, and that was in 1978 in the advanced setting. That's for metastatic disease. So in the 80s and the 90s, it became what we call the era of targeted therapy. That's when we started realizing that instead of just throwing a chemical at the body trying to hit quickly growing cells, maybe there's something unique about these cancer cells we can identify to try to get our drugs more directed and to have fewer side effects. The side effects were kind of the motivating force behind targeted therapies. And at the time, they came in kind of, I call them two flavors. There were monoclonal antibodies, which were our bodies all make antibodies to attack foreign things in our bodies. And so whenever you have a cold or something, you make antibodies to try to get rid of them. So scientists decided, well, why can't we engineer these antibodies and put something on them that makes them look like, first of all, make them target something on the cell, the cancer cell, and make it, whatever we're sticking to the cancer cell, make the body think that it's foreign so that your immune system is kicked up and will attack it. And so monoclonal antibodies did that, and small molecules, which were very similar, but they actually went into the cell, not attached to the cell, were our first foray into monoclonal antibodies. And that's where we developed trastuzumab, or Herceptin, which is one of our early successes in breast cancer. Gleevec is a pill that we use for chronic myelogenous leukemia. Avastin is a monoclonal antibody, and they're given IV as well. And cetuximab, which is Erbitux, which we use, colon cancer. Those were all examples of targeted therapies back in the 90s. And in 1997, there was a monoclonal antibody called rituximab that was actually our first targeted immunotherapy. And we hear the term immunotherapy all the time. And there are several different types of immunotherapy, not just one, but the focus is, instead of, trying to directly go to the cell and stop it from dividing, which is what our classic chemotherapy did. It disrupted the growth cycle. It tried to do something to the cell that would make your body think it's foreign and kick in its own immune response. And so you're using a lot of your own forces against the cancer, which again, the hopes was it was less toxic too. And so rituximab in 1997 was immunotherapy for non-Hodgkin's lymphoma. Let's see. And when we look at the treatments from 2000 to now, I call that the era of immunotherapy. It spanned a large period of time up to the present, where we're still developing new types of immunotherapy, because people feel, and I agree, that your immune system is going to be a huge part of having a lasting effect in treating cancer and keeping it away. There were 2 approvals of therapy before the 2000s, which were actually directed towards your immune system. So I want to give credit to those who work with interferon, which is a cytokine that your body produces, but it kicks up your immune system. It was used in melanoma and hairy cell leukemia and back in 1986. And that 1990, we had a vaccine. Vaccines are developed to kick up your immune system. And BCG is a vaccine that we used against tuberculosis, but it was also found to be effective in bladder cancer. And we still use BCG vaccine in bladder cancer today. But in 2000s, we started trying to get innovative and get better treatments that involve the immune system. And the very first human cancer treatment vaccine outside of the BCG is Sipuleucel T, or Provenge, for prostate cancer. And that was in 2010. And some people are maybe familiar with it because there was a bit of a controversy. Sipuleucel T is interesting because what they would do is the company that made the drug had a lab. And so if you had a patient with prostate cancer that was metastatic and met criteria, you would send the lab part of their cells, their tumor cells, and they would take the cells and you'd also send the white blood cells of the patient. You'd do an IV type of procedure, and they would kind of put them in and let them incubate for a while, and they would develop their own personal vaccine out of their technology that is specific to your tumor, and then give the cells back to you as an oncologist, and then in a special way you infuse this vaccine back into them over the course of 6 weeks. And it was good in a certain subsets, and they're still not even exactly sure which subsets say, you meet certain criteria. It wasn't a home run for everybody. It was super expensive. And I'm trying to remember, it was like $96,000, but there was controversy because the FDA, did not feel that the benefit that was seen from this drug was worth, the costs, really, or the risks that some people had with Sipuleucel. It was fairly safe, but but the advocacy groups for this drug were so fervent. I mean, they really wanted this drug to come out. They were following it, and there were death threats to the FDA investigators who didn't want to approve it. But ultimately, sipuleucel T was approved. And it was used, and honestly, I used it in treating some prostate cancer patients who actually did well. They're still studying it, trying to find out what it does. But one thing that it does do is it does affect the immune system in a way that they're still trying to understand. So that's one of the things about medicine that I think is so interesting, that sometimes you can learn after the drug is approved how it can be better used. And one thing that we started to notice is that the PSAs, even if someone progressed on or recur, or their disease started to grow after getting sipuleucel, everything you used after tended to work a little better and a little longer than they historically did. So there's a thought that it does something to the immune system that helps support it a bit. So anyway, that was just anecdotal about sipuleucel. And so 2011, next year, was the first checkpoint inhibitor that was approved. So checkpoint inhibitors are the most, I think, the most familiar to people who know about chemotherapies and have heard about immunotherapies. So checkpoint inhibitors are therapies that target a certain marker on the cell program death 1 is the PD1 and the PDL1. People probably have heard that. These are anti-PD1 or anti-PDL. And then there's the anti-CTLA, which was the very first checkpoint inhibitor approved. So those are the two types of targets for the checkpoint inhibitors. The first one approved was ipilimumab or Yervoy. And after that, the most common one, because we use it in breast cancer, is pembrolizumab, Keytruda, which is approved in like 17 different indications. I mean, that drug is effective, different variances of being effective. Again, not a total home run, but very successful either alone or in combination with chemotherapies in all types of cancers, head and neck, colon, lung, breast, anything. So the checkpoint inhibitors, there are 4 now. There's Yervoy, there's pembrolizumab, which is Keytruda, there's nivolumab, which is Opdivo, and then there's atezolizumab, which is Tecentriq, which we use in breast cancer. Yes. And if you follow that, Tecentriq was approved in the metastatic setting in breast cancer, and then it looked like it was going to get approved in the adjuvant setting, but it didn't quite make it, so they took that approval away. So we're inching towards finding the right drugs for the right diseases. Another type of immunotherapy that was used was the oncolytic virus, which is the use of a virus to intercalate and to get it to go inside the cancer cell and divide it and disrupt it and make it immunogenic. So the virus will get incorporated into the cancer cell, and the body will identify that there's a virus there, and the immune system will attack it. So in 2015, from the herpes simplex virus 1 came TVEC or I can never get this whole word out, so Telimagene, and I won't even try the second part, but I call it TVEC. And we use that for melanoma, and we're actually doing some studies, a similar drug in breast cancer, and you inject the tumor. So this is not one that goes through the IV systemically, you actually inject it. And some people have concerns, about injecting a virus, what does that do, especially if someone is immunosuppressed, but it's been very successful in melanoma. And then you may have heard about CAR T cell therapy. And CAR T therapy is a T cell manipulation, an engineered T cell antigen that is used to try to, again, target something on the cancer B cell, is where they're using this in non-Hodgkin's lymphoma and acute lymphoblastic leukemia. And cause your immune system to identify it and kill the disease. And there's a lot of interest in CAR T cells. There's something about the T cells that we think are going to be really effective. But it hasn't yet, we haven't found the right combinations for everything, because it's being treated in many, many different tumor types. But there is an approval for Kymriah. That one too, I have to work on. Kymriah for the Hodgkin disease and ALL. And then in 2018, Yescarta, Gilead's drug, was approved. The problem is CAR T cell is so expensive, $400,000 per treatment for the full treatment for a patient. So we have work to do. We're getting good treatments. We have to figure out how to do this and do it so that people are not, broke by the time they're done with treatment. And anyway, that's a whole nother story about policy and the cost of some of these new drugs. That's all of what I'll talk about in the general chemotherapies. And these are just some very basic milestones. 1940s, honestly, that was the nitrogen mustard, which wasn't used much in breast cancer. I would say adriamycin was our first drug that was approved, and it was approved in 74. So the chemotherapy for breast cancer, honestly, started in the 70s. We also had tamoxifen for our hormonal therapy being discovered, not approved yet until the 78. And it was interesting, tamoxifen was approved for the metastatic disease in 78, but it wasn't until, I think, 20 years later that it was approved after the STAR trial for prevention and in the adjuvant setting. And so the development of not only, drugs, making sure they're safe and effective, but the indication where they're used can take so long. And that's something that we're still working at on ways to kind of speed up the process of drug development so it's still safe and effective. For breast cancer in the 90s, that's when we started seeing the targeted therapies like Herceptin. And that was a game changer for breast cancer that was HER2 positive, because women who were found to have the HER2 protein overexpression had a much worse outcome. Their disease just recurred more. It was a faster growing tumor. And the use of Herceptin, once trastuzumab or Herceptin was developed and used, it equaled the playing field. It took that whole disadvantage and brought that woman's chance of survival and benefit the same as someone who didn't have HER2. And you don't always get a drug that's good, that is that good. And then in the 2000s, again, the newer immunotherapies that we're using in breast cancer now. Okay. And I just chose three overall kind of overarching advances that I thought were important recently. And one is immunotherapy. And I talked a lot about that already, but I think that is going to be the way that we're going to have some really, really big improvements in the treatment. Personalized medicine. So personalized medicines, we've been talking about that through my whole talk, but it's just a way of identifying markers. We call them biomarkers. You'll hear that term too, or targets. But instead of just, again, taking chemotherapy and just giving the same chemotherapy to everybody and hoping that you get a good response, we look at that person's specific tumor and we test for the biomarkers that we know that are important in their disease, be it estrogen receptors or HER2 or PIK3 or anything that we think affects that cell. So the markers can do two things. They can give you information about how that cell actually grows, right? That's prognostic information, or how its natural history will be. But the predictive information we get from the markers tells us what treatments are going to be effective on that cell too. And so that's the important part. And when we're talking about personalized medicine and these markers, it allows us to know, okay, we can use, tamoxifen or aromatase inhibitors in this woman, and it's going to work because she's got estrogen receptors. And then advances in supportive care. And so these are the side effects. I didn't go over a lot of them. The most common side effects of classic chemotherapy that we talked about more in the beginning were side effects from the chemical or the chemotherapy affecting your normal cells. Again, the therapy was targeting faster growing cells, but things like your hair follicles, your fingernails, the lining of your stomach, they all are kind of turning over too and can be affected by chemotherapies, different ones in different ways. But that's how we get the nausea. Your bone marrow is constantly, turning over cells. And so the chemotherapy affects your bone marrow. That's why we're always checking your blood counts if you're on treatment to see if you're neutropenic. The hair loss. And the goal with these newer therapies are try to minimize side effects as much as possible. So targeted therapies are good at that. What we're finding, especially with immunotherapy, and we don't totally understand this, is that we may be manipulating or revving up some immune responses in other parts of your body, and things like inflammatory type of side effects, like try to think of something that's not esoteric, like thyroiditis. With when you're using the checkpoint inhibitors and some of the other immunotherapies, they check your thyroid all the time because it can cause inflammation of your thyroid. It can at times cause inflammation of the liver too, a little hepatitis. So it can cause the adrenal glands to get a little inflamed. And so these are new side effects. And so we've had to learn, since these drugs are on the market since the mid 2000s, to start looking for them in different ways, try and develop ways of avoiding them as well. Some of the drugs now can affect the eye keratitis. And so we're using eye drops to try to prevent that with some of these drugs now that we know this. I think my last slide just had some of the common side effects that I went over, nausea and vomiting, and we have anti-nausea drugs or antiemetics for that. Hair loss, and we'd say wigs and scarves, but also cooling caps are available. I don't know if people have used or heard or used them, but they are coming out with more effective cooling caps, so women have a less chance of losing their hair. Fatigue is a common side effect, and we have growth factors for that. I'm sorry, neutropenia is low blood counts, which causes fatigue, and we have growth factors for the low blood counts. Fatigue, of course, is just, pacing yourself and knowing when the side effect hits you the most. So the advances we've talked about a little bit already. So I think that was it. My last slide. I want to thank you all for listening.
Thank you. This was really wonderful. And just to the group, it made me think of, I don't know who has seen this or perhaps even read the book, but back in 2015, Ken Burns did a documentary of the Emperor of All Maladies book. And it was beautifully done, very sad, but also beautiful at the same time, and talked a lot about what Dr. Horton was talking about. So some of the more barbaric surgeries for breast cancer up to the immunotherapy and the T-cell trials. There was a segment on the Herceptin trial. So really, really interesting. If you want to delve more deeply into some of these topics, I watched it while I was going through my treatment back in 2015, and can't recommend it enough. So just an aside there. But we do have some questions that have come in, Dr. Horton. We've got about 14 more minutes until the end of our time. So one is kind of neoadjuvant versus adjuvant chemo. We have members of this group alone who have very similar diagnosis, history of diagnosis, but some have had neoadjuvant chemo while others have had adjuvant, even for triple negative breast cancer. We've seen both. So curious kind of your thoughts on why some people recommend neoadjuvant versus adjuvant chemo.
Okay, that's a great question. When I was putting this together, there's so many interesting things that you could talk about chemotherapy. I said I'm going to forget something huge, but yes, the neoadjuvant, so I'll talk about that. I just want to mention very quickly, you mentioned Ken Burns' show. And I don't know if you remember the woman, the breast surgeon who had the breast cancer, Lori. She's my very, very good friend. And I was the medical oncologist at the same place she was the breast surgeon. So we were like attached at the shoulders all the time. So that show we lost her last year, but she was amazing.
She was amazing. I'm sorry to hear that. She was incredible.
But that he did such a great job, Ken Burns, with that.
He did.
So neoadjuvant chemotherapy is wow. So the idea of neoadjuvant chemotherapy started probably in the 90s, late 90s, early 2000, where we started thinking about, it was all about breast conserving therapy initially. Women who were having to undergo, mastectomies, who wanted to keep their breast. Is there something that we could do early on to help to shrink down the tumor so that the surgeries are less, just debilitating? And then, of course, from a medical oncologist standpoint, we're like, yeah, let's get this chemotherapy in first and, take care of any micrometastatic cells or cells that would become micrometastatic to decrease the chance of recurrence and hopefully increase survival. So the first clinical trials that used neoadjuvant chemotherapy, and I'll say what they did is they identified women who they thought, well, the criteria for it was one, the breast cancer had to be such a size that the woman would have to have had a mastectomy, right? So the criteria they were using was about 2.5 centimeters, or node positive 2. And they wanted to use women who had a higher likelihood of the cancer recurring, meaning that they probably would have had the recommendation to have chemotherapy after surgery. So if someone had like a 1 centimeter, very small stage 1 breast cancer, they would not feel she would be a good candidate for neoadjuvant chemotherapy because we knew the cure rate was so high with surgery, and surgery in that size could be done with a lumpectomy if the woman wanted it. So there's no real advantage, chemo first. So the studies were done with women who had larger tumors to try to see if we could shrink them down so that they could have a lumpectomy if they wanted. And they found that you could see some really significant shrinkage in a lot of the women. When they followed the women out, in the first studies, we were looking to see if we'd have less of a recurrence or we'd have a higher survival too. That's an even more of a reason why you would want to give certain women the chemotherapy up front. And the first studies were kind of, on the fence at about, 3-4 years. We're like, definitely it helps a woman to achieve a point where she could have a lumpectomy by getting chemotherapy first in a lot of women. But we can't say you should get it up front because it's better for you and you're going to live longer. So the indication for neoadjuvant chemotherapy when it first came out was to, shrink down the tumor size to make a woman so that she could have breast conserving therapy. So that was the indication for it. People still believed that with time we were going to identify women who actually would get a survival benefit, meaning that they would live longer by getting chemotherapy up front. And as time went on and we followed women longer, the problem with clinical trials in this curative setting, it's wonderful. It's a curative setting, but it takes a long time to follow out the women long enough to identify when breast cancer comes back. It may be 5, 6, 7, 8 years, even longer, to be able to say, or survival too is even longer. You're following women until they they die, and it could be, 20 years, 30 years. So as these clinical trials are maturing, we call them, getting older, and we're getting more information from them. And again, these started, maybe 15 years ago. So we're starting to get enough information that we feel comfortable making some clinical, I won't say assumptions, taking the clinical results and feeling that they are valid, is that we know that a woman who takes neoadjuvant chemotherapy, and right now the indication is 2.5 centimeters or larger, or if you have advanced disease to the lymph nodes, that meets most criteria for neoadjuvant therapy. Or if your body habitus is that your tumor would require a mastectomy and you wanted to have a lumpectomy. That if a woman gets the chemotherapy up front and she has what's called a pathologic complete response, meaning that from what we can see clinically, but with your eyes and your hands, it looks like it's gone away. And then when you do a scan, be it an MRI or a mammogram, there's no evidence of it, and you go to surgery, and whatever surgery, be it lumpectomy or mastectomy, is done, and they don't find any evidence of cancer cells in the specimen. That's called a complete pathologic complete response. And we're finding that women who achieve that do have a survival benefit, and that was huge in neoadjuvant. And so this is all still kind of new that we're getting this information. And so the neoadjuvant studies are still being done. There are different ones using different treatments, because we know that getting the chemotherapy up front is just as good and maybe better in some instances than getting it afterwards. We started looking at the chemotherapy, which is a pretty long, 3-month, could be 8 weeks to 12 weeks deal. And it's usually the adriamycin and the Cytoxan and the taxane. So it's whatever you would have gotten afterwards, you just get it before. And we're now looking at other novel drugs based on the tumor, maybe using a PD-L1 up front. And this is all in clinical trials to see if we can obtain complete responses with therapies that are shorter, less toxic than your ACT, and take the women to surgery and follow them out and see if we can have new standards that are more tolerable and shorter period of time. But again, that's in active trials right now.
Wonderful. Okay, thank you. Another question that came through is, does the pace of new cancer development, new cancer treatment correlate with the amount of dollars directed to the research? So through the NIH or the FDA, how does funding impact research?
Yeah, funding is huge. It's huge. For a lot of reasons. You can't do, the work, the clinical work, unless you have funding. And for, I don't know what the exact numbers are, but for, every drug that gets approved, there's a lot of drugs that are tested and money is spent that don't make it. And so it really is, it's difficult, because to get that, that gem, you go through a whole lot of junk, unfortunately, that doesn't benefit people. And because of that, policy is important. Having people in government who believe that research is important is key. It tends to be one of those things, research tends to be an area where sometimes, the politicians feel we can cut money, and especially it's unfortunate that sometimes, unless it's affected you directly, people don't understand the impact that cancer has. And you'll see that, there'll be a politician whose, spouse was affected with pancreatic cancer, and all of a sudden, there's a huge push, whatever it takes, I'm taking it. But so we have to try to get in front of these people and have our stories told, and go to, like I came from today, this afternoon, I went to Capitol Hill for TNBC Day to talk about with the advocates their experiences, so that, you know, the politicians will understand, you know, your congressmen, how important some of these bills for funding are, like the TNBC bill that's coming up. So the one thing I think that's saving research from when I started, because there was a huge cut in the funding from the government for cancer research, probably around the early 2000s. And so, you know, institutions and researchers were just fighting for those dollars. You know, there's a lot of competition, a lot of research, good research didn't get done. But at that time, working with pharmaceutical companies was considered, you know, not the thing to do, that it would put bias into your study. And it was kind of looked down upon for researchers to partner with pharma. And luckily, I say luckily, because I think that a lot of good has come out of those partnerships.
Mm-hmm.
The pharmaceutical companies are doing a lot of research that they are partnering with academic researchers, and in a way that the science is, you know, it's the integrity of the science is sound, and not that it wasn't before, but there are a lot of eyes on it. And it made people a little bit more comfortable with the data that's coming out. And in the, you know, the pharmaceuticals have the resources to fund really good research, and they're attracting a lot of good people too. And so that's kind of where it is right now. The government is not kind of the major funder of research. It tends to be pharmaceutical companies.
Okay. Thank you. We've got about 2 more minutes. So just a quick question about side effects. And I'm kind of merging two questions here now. Has there been any kind of research or studies based on how to kind of change the chemo agents slightly to help reduce the side effects, like neuropathy? How, you know, how can is there anything that's being done to the drugs themselves that would help reduce the side effects?
Yeah, neuropathy is a tough one. There are a couple that are just like tough. They're,
Yeah.
you know, everything's been thrown at them, and it really hasn't made much of a difference. But yes, so for neuropathy, for instance, formulating the drugs in different ways, maybe the mediums that they're infused in sometimes was thought to maybe help with neuropathies. The taxanes, like Taxol, that's where nab-paclitaxel, you know, what's it called? Albumin bound nanoparticle type of Taxol was it. That's called Abraxane, if you didn't know the brand name. So it was developed and kind of touted as this. It has a cremophore way of something covering of it that was supposed to decrease the neuropathy effects. And you know what happened was it decreased the immediate neuropathy effects, but long term you still had this neuropathy. So it was a little different. It wasn't a home run, but that was just an example of, you know, specifically developing a drug to try to decrease the side effects.
Yeah.
Yeah.
Interesting.
Yeah.
Awesome.
Neuropathy is tough.
Well, I'm sorry to say that we're out of time. I could chat all night and probably come up with 100 more questions, and I'm sure that everybody else could too. But just want to take a moment to thank you for putting this together for us and to going into such great detail about the history. And, you know, I personally am very grateful for people like you. Thank you for advocating for us, and you know, for taking the time to do this. So really appreciate it, Dr. Horton, and hope that you can join us again sometime.
Absolutely. Thank you. I appreciate it.
All right. Thank you. Hope you all have a wonderful evening.
You too.
Bye.
Bye.